Right. Hello, everybody. Welcome to our continuing education series, Joining Forces, Empowering Voices, a collaborative approach to supporting adults using high-tech AAC. My name is Erin Edwards. Through this series, you'll find that we're passionate about building greater collaboration between BCBAs and SLPs. So all of our webinars will offer CEUs for both professions. We are also invested in improving services for adults with disabilities. So most of the examples and discussions in our presentations will focus on adults, but many of the interventions and techniques can be applied to children as well. And finally, we're passionate about the potential of high-tech AAC. So all of our webinars will include information on that type of communication. This CEU series is brought to you through the generosity of the Edith L. Trees Charitable Trust. We are very grateful for their support and this opportunity to bring you some amazing speakers over the next year. We hope this makes a difference in your practice as a professional and in turn makes a difference in the lives of the people who you support. So some important CEU information. I will put this website, email, and the direct CEU links into the Q&A, and you'll also receive them in a follow-up email from the event tomorrow if you attend it live. If you're new to our series, you'll need to create a profile with a login and a password to our learning management system website before you can access the quiz and evaluation to earn the CEUs. There's a step-by-step walkthrough on how to do this on our website under the Earning CEUs tabs. It takes a minute or two to get it set up, but you only have to do it one time. And we're presenting webinars monthly in 2025 from January through August, so you're not going to want to miss out. Check out our website for our full 2025 schedule. And finally, if you have any technical questions or issues completing the post-work to get your CEUs, please use this email address here to let us know, and we can try to help you out. If you have any questions during the presentation, please put them in the Q&A. I'll be watching it and asking questions to our speaker as they come up. You might also see some comments or questions labeled as clarifiers. Since we know we have a mixed audience of BCBAs and SLPs, sometimes with different vernacular, our team may add some comments or questions to make sure both professions are understanding the material the same, even if they're using different words to talk about the same concepts. And now it is my pleasure to introduce our speaker, Lissa Power-DeFeur. So Lissa is a professor emeritus at Longwood University, where she was the founding director of the graduate program, department chair, and interim college dean. She earned her graduate and undergraduate degrees at the University of Virginia. She's previously worked as a clinician in early intervention, schools, and rehabilitation settings, and as a special education administrator at the Virginia Department of Education. She's an active volunteer for the profession, serving on various boards and committees for ASHA and her state association, including the ASHA Board of Ethics, and as the ASHA Vice President for Standards and Ethics in Speech-Language Pathology. She was awarded Fellow in ASHA and her state association. She has taught and published on ethics for 20 years and is frequently an invited speaker on ethics, the nexus of special education and speech-language pathology, and various other topics. She is currently teaching the AAC course for the University of Virginia's graduate program. And we are so happy to have you today, Lissa. So I am going to go ahead and stop sharing and allow you to share your screen.
Okay.
I think I will.
Thank you very much for that kind introduction, Erin, and for the opportunity to be part of this great series. I had the opportunity to watch the recordings of all of the series thus far, all of the sessions thus far, and there's really some fabulous presenters. And I know if you're watching this live or on a recording that you are really committed to improving services for adults with developmental disabilities and complex communication disorders, and working collaboratively with our partners across BACBs and speech-language pathologists. So can you see my slides correctly, Erin? Okay.
Yes,
good.
It looks good.
Yeah. In terms of my disclosures, I just want to be clear that I'm getting an honorarium funded by the Edith L. Trees Charitable Trust, and I think my other non-financial disclosures, Erin included in the introduction. Thanks very much. Our objectives tonight are that at the conclusion of this session, that you will be able to describe an approach to resolving ethical challenges, that you will have a sense of comparison between the ASHA Code of Ethics and the BACB Ethics Code. And then ideally, you will leave this with some strategies you can use when you are facing ethical challenges, whether they relate to working with this population or any other population. And I just want to reiterate how fabulous the presentations have been thus far. I've really enjoyed hearing from Laura, from David, from Richard, from Barbara, from Julia, from Dawn, from Erin, from Shannon, and comments from Jonathan. It really enriched me, and I know that will be the case for everybody who's participating in this series. My agenda tonight is I'm going to talk a little bit about why we care about this, the background and rationale. I'm going to go through a multi-step approach to resolving ethical challenges. I found it fascinating to do a review of the ASHA Code of Ethics and the BACB Ethics Code, which I'll review with you. And then I will apply this multi-step ethical decision-making process to some ethical challenges. So I've got 5 ethical challenges that maybe you have. Oh, I'm jumping ahead. I skipped over my first background. All right. Why should we be concerned with ethics as BCBAs and SLPs? I always ask this question when I teach my ethics class, and it's fascinating to hear what 22-year-olds and 23-year-olds will say about why they should be concerned about SLPs. But these are some of the reasons you see in the literature. First and foremost, it's provide for the welfare of our clients and students. That's why ethical codes are so heavily based in healthcare, that the concern is for the individuals we are serving, that we meet their needs and we are promoting their best welfare. We want to adhere to the highest standards of our profession. We have standards of conduct, whatever profession we are in, and when we are acting ethically, we are meeting those high standards. Well, for heaven's sakes, we want to avoid harm. It kind of goes hand in hand with meeting the welfare of our clients and students, but I think that we also recognize that there's kind of another part of that, which is avoiding harm. And oh my goodness, there's a terrible story here in the Richmond area. I'm in Richmond, Virginia, about a nurse in the NICU who was causing harm to some of the babies there, and how the NICU had to be shut down. And it breaks the heart of any helping professional. Be competent. We need to be at the top of our game. We need to know what we're doing. We need to be current in our knowledge of evidence-based practice, so therefore we can provide for the welfare of our clients and students. Treat our colleagues fairly. Well, isn't this all just about the clients we serve? Yeah, but how do we serve the clients if we are not working collaboratively and well with our colleagues? Do the right thing. That's what I often hear from college students. And then, of course, we have professional standards. We have codes of ethics that we need to comply with. That if we don't meet those ethical standards, or if we are found in violation, we may have our certification and membership revoked. We may have a complaint filed with our licensure board, lose our license, lose our certification. And so clearly we want to make sure we do the right thing by complying with ethical standards. All right. Now I'll go to those ethical challenges. And I really want to thank Erin and Laura. I met with them for a little while, about a month ago, to talk about typical scenarios, and I appreciate their review of my draft and improvement upon them. So these are the scenarios we're going to come back to. So I'm just going to go over these now, kind of mention what the situation is. Then we'll walk through a decision-making model, compare the 2 ethical codes, and then we'll come back and apply the decision-making model to these 5 scenarios. So AB uses a low-tech AAC device, a multi-page board with icons representing common needs like bathroom, water, and people, icons with mother, father, boy, girl. The device was created by the BCBA working with the family in the home, and AB uses it effectively to communicate basic needs. In school, the SLP identified the need to broaden the vocabulary and organize the icons in a method that will promote syntax knowledge. The OT identified that AB has difficulty accessing multiple pages due to fine motor challenges. I don't think it's uncommon to see as persons who use AAC devices transition from one setting to another that we need to be mindful of how things need to have changed, and maybe we are not really thinking about what's needed in the next area. So we'll come back to that one. Number 2, we have AC, who's a young adult with autism and DD living at home and started attending an adult day program 3 days a week. AC concluded IDEA services 5 years ago, aging out at 22. While at school, AC had a speech generating device, but does not have any device at the day program. So the SLP who serves that program asks the family and learns it hasn't worked in years. My third scenario is AD. 23-year-old with autism and DD recently began a community and residential services program through the adult services program in the community. Also received IDEA services, of course, including SLP, ABA, and OT. Non-vocal, no functional mean of communication. In reviewing the records and talking with the family, it seems that AD was expected to meet certain prerequisite skills of attention and language prior to any consideration of an AAC device. The phrase, "it's too early," was found in the record. Sad situation, I think, that we all have seen perhaps more often than we'd like. Scenario 4, we have AE as a teenager with complex communication needs who communicates with a speech generating device with a backup low-tech device. The interprofessional practice team working with AE in school notices that AE's one-on-one paraprofessional regularly takes AE's hand in a hand-over-hand position and creates AE's communication on both devices without alerting AE or asking permission. And then my last scenario, number 5, about collaboration. We've got a new house manager at the residential home, and this new house manager notices frequent complaints by the direct support professionals, as well as the contracted and external providers. The house manager hears such comments as, "So-and-so is serving as a SLP or OT or BCBA," but we know that person isn't in that case. "So-and-so always insists on their own way, and I hate going to team meetings." So we've got a problem working with our peers. So those are my 5 scenarios that we'll come back to after we look through a decision-making model. So let's dive into a multi-step approach to resolving ethical challenges. These are common across health professions. I've read ethical decision-making models in a variety of healthcare publications, from physicians to nursing to allied health professionals. And then most recently, as I looked through the BACB ethics code, it's a very common approach. You're going to find some are 5 steps, some are 10, some are 12, but if you distill them, they're all talking about the same concepts. And so I've got 7 steps here for us. So our 7 steps begin with, what is it you want to accomplish? What is your goal? Now that you've heard about this, or you're in the midst of this, what do you want to do about it? Next step is learn everything you can about the situation. I heard this expression recently, and it really applies here. Be curious, not judgmental. It's pretty easy to be judgmental, isn't it? Especially when we hear something that really just plucks our last nerve. We are really unhappy with what we have heard that's going on. So we want to switch to being curious. Think about this problem. Is it ethical? Is it a legal or policy problem? Is it a moral problem? Or 2 of the above, or 3, all 3 of them perhaps. Then research policy and practices to inform your approach. This is different than B. B is learning about the situation. D is learning about what policy is out there, what practice is out there, what regulations are out there that we must be complying with. Then E is brainstorming possible approaches to resolution. Brainstorming, everybody's done it. You're coming up with a variety of ideas. And as you're brainstorming, then you consider the likelihood of effectiveness. Is this going to make the difference that I hope to make? Then select your approach. And as with everything we do, we should reflect. Did this work? Did I do it the right way? Did it make the difference I was hoping for? So let's dive into each step. What is it you wish to accomplish? Is your focus on ensuring the welfare of the client? Well, I certainly hope so. That should be our primary focus. But I've got to tell you, when I provide ethical scenarios to folks, that is not the first thing people come up with. They see something that's a problem and they drill down to the person who's causing the problem. Very natural human response. We tend to focus on who is doing something wrong, as opposed to taking the higher road of saying, how do we move forward to serve the client better? Sometimes people want to justify our own viewpoint or beliefs. I know that I'm right. I know this person was wrong, and I want everybody to know that I'm right and they're wrong. Like it or not, that's a pretty natural human behavior. Do you wish for someone to receive consequences for their actions that you believe are problematic? I'm here to tell you there are many times that's really appropriate. As Erin said, I served on the ASHA Board of Ethics, and I heard some things that just appalled me, and those people absolutely needed consequences. We also heard some things that might have just been a little retraining, a little redirection would solve it. But so you're going to see the gamut of consequences and solutions based on what somebody has done or has not done sometimes. And ideally, we want to get to this one. We want to change the practice so it doesn't happen again. We've seen something, we've heard of something that happened that concerns us. It's not meeting the welfare of the clients. Not only do we want to reteach that individual, but we want to make sure that we set up a system so it doesn't happen again. So B is learn everything you can about the situation, everything you can. You want to go through the information you got and decide what is relevant and who are the relevant individuals. Like it or not, there are some people who just like to talk or are a bit gossipy, or they are problem talkers, that they like to talk about troubles. And sometimes those folks who really like to talk about troubles have a distorted view, and they may not be giving you all the information. Or they may have gotten something by hearsay, but present it to you as if it's a fact. And so as you are listening to what you've learned about the situation, your first step is, who do I need to talk to? Who are the people who are involved? What do they know about the situation? Can I get that? So you want to gather as much information as possible and identify what's relevant. You know, when people are unhappy with something, they often throw in extra information. I know I do that. I'll have a conversation with my husband about something, and he'll look at me when I say something and, oh, no, that doesn't relate at all, does it? I just kind of went on this kind of negative tangent, and I'm including everything. So go through and decide what's really pertinent to the situation. You're going to hear a lot of stuff that's secondhand, that you don't know yourself whether it's true or not. It may be that you heard it from somebody you trust. It might be that Erin heard it from Jonathan or Laura heard it from Erin, and you trust that person. That's great, but you want to verify it yourself. You want to make sure you have as much information as possible so that you know you can stand behind every piece of information you have. And then you want to determine what you don't know. One of our secretaries of state or secretaries of defense commented, I'm going to think of his name about 8:20 today, said that there are those things that we know and there are things that we don't know, but what we really need to worry about are the things that we don't know, that we don't know, we don't know. And I think that is exactly the situation here. What is it you don't know that you aren't even sure you don't know? So take time to think about it to make sure that you can figure out what those elements are. And then, can you get it? Sometimes this information is confidential and you don't have access to it. You are not one of the privileged people who has access to it. So you are really relying on secondhand information. Does that mean you do nothing? I would say probably not. Sometimes you are stymied and you can't do anything because you've only heard it secondhand and you can't verify it. But in general, there usually is an action you can take of sharing it with somebody who does have the authority to gather the information that's needed. So as I said, be curious, not judgmental. Oh, we need to consider whether we might have any biases about the situation. You know, that I love this grant program, this training program, because it's getting BCBAs and SLPs to collaborate together. And we certainly had that great presentation from Erin and Shannon about what you're able to do through collaboration. But I think one of the reasons you're doing this is because that's not the norm. There is not always a great connection between BCBAs and SLPs. And so sometimes one side or the other may have a bias, and we have to check that bias. And I just don't mean to pick on BCBAs or SLPs. It could be the person who works at another university or at another clinic, or somebody that is treated your best friend poorly in her first job. That we bring these biases to the situation and it filters what we have, what we think. A couple quotes that I like. If you are convinced of the facts before you start investigating, even the smallest bit of evidence that seems to match your presuppositions will blind you to the full story. We often look for the information that matches what we have to say. Sorry about that. And a long time ago, Harper Lee in To Kill a Mockingbird told us, people generally see what they look for and hear what they listen for. Then our next step is to look and see, is this an ethical issue, a legal policy issue, or a moral issue? And you'll notice that these are overlapping circles, that they generally are not distinct, that you generally will find that they overlap pretty clearly. Some examples is ethical, as we both have ethics codes in both professions. Legal and policy, we have IDEA, we have ADA, we have 504, we have Medicare, Medicaid, we have agency policies that we need to comply with. And moral is our own personal moral code about what we need to be doing, what's the right thing to do. And our next step, dive in and research policies and practices. And I highly recommend that you develop your own knowledge to inform your response. And I'm not saying that there aren't a ton of wise people out there that you want to talk to and you want to learn from, but put it all together and own the information yourself. Make sure that it is what you have decided is the right or the wrong thing to do, not what you've been influenced by somebody else. So what policies and practices are you going to look at? Licensure. I should have added certification there, depending upon where you are in the country. You may have one or both terms affecting your practice. Federal and state special education, that many of these young people that are using AAC devices are still governed by IDEA through their 22nd year. We have ADA and Section 504 of the Rehabilitation Act that talk about the importance of communication. The individuals we are serving are frequently covered by Medicare, Medicaid, and/or private insurance. We want to make sure that we know what those policies are, and those policies for Medicaid vary from state to state. So if I move from Virginia to Pennsylvania, I can't assume that the Medicaid rules for persons that are living in group homes with complex communication needs that apply here in Virginia are going to be applying there in Pennsylvania, for example. FERPA, of course, in the K-12 situation or higher ed situation, and then HIPAA in terms of confidentiality management of records. Child and abuse reporting are very critical. We are all mandated reporters, and we need to know not just what the law says, but we need to know how it is implemented in our state and in the agency with which we work. What are the standards there? And then, of course, we have our ASHA and BACB ethical standards and guidance. And you don't just find the codes on the web and have to read it yourselves. Both organizations have a lot of information to help people interpret them. There are additional resources. So when a professional is stumped by, okay, now what do I do now? There is probably going to be some additional information on the professional websites to guide you. And as I get into talking to people, I'm also going to recommend make sure you talk to people in the professional association as well. So what I've talked about in the left column are federal statutes and regulations, state statutes and regulations, and our professional standards. We also have local standards, that there are personnel standards regarding the hours somebody should be working, the nature of how they're doing their record keeping. There is harassment, which can show up as we're dealing with collaboration issues. There are timelines that are required by every employer we have. We've got documentation standards. Clearly, Medicare, Medicaid, IDEA expect documentation, but our employer probably has a particular way it needs to be done and a time frame for how it needs to be done. And then our caseloads, how large is a caseload that we should be taking? This is a ton of work. It is absolutely a ton of work. And I just want to share a story about myself to remind everybody listening that don't assume what you used to know is what you know now. When I worked at the Virginia Department of Education as a director in the Special Ed and Student Services Office, the implementation of Medicaid in Virginia special ed programs was under my responsibility. As a result, I knew the Medicaid standards very well for how they were applied in special education in Virginia. Well, I had the opportunity to go back to higher ed and went to Longwood and had that great opportunity to start the grad program. And I'm in a meeting about Medicare policies regarding speech language pathology services. And I piped up and said what the standard was. Well, that was the standard, but it was no longer the standard. And it's just a reminder of, we know it really well at a certain point in time. Rules, regulations, policies change. So double check them and make sure they haven't changed. I ate a little crow. I apologize, but boy, has it become a great story for me to be able to share my own failing at keeping up to date and assuming that what I knew really, really well at one point in my career had changed. I also recommend you find people to talk to. We frequently need somebody to talk to kind of process what we're hearing. We need someone who will talk to us and ask us tough questions, will often challenge us if they notice that we're getting a little bit of a bias thrown in. They will challenge us if they're thinking, it's just been a really long, tough day for you. Maybe you want to begin looking at this again tomorrow. So who are some of those people? A former student of mine commented that when she was a resident advisor at Longwood, they told her to get a board of advisors when they had tough situations as resident advisors. And I think that is a great concept, that have a group of people that you can talk to when you're facing a tough situation that will listen to you, talk it through with you, but not necessarily tell you what to do. They will guide you in asking the right questions so that you are better informed as you get to the point of making a decision about an action. So these are people you work with that you trust. Former faculty, for those folks that, we all have former faculty that I know I revered. When we started our grad program, I had the opportunity to visit with some of my faculty member, and, I feel like I'm at the feet of God, even though, we're now colleagues at this point in time. But so talk about former faculty. Talk to agency representatives. Call the licensure certification board. Ask them, what are the requirements? Call the folks in the special ed unit. That agency representatives have an obligation to provide technical assistance and answer questions. Call the Medicaid office. I'm not sure in Pennsylvania how they organize programs for adults with developmental disabilities and ID and autism, but in Virginia, it's the Department of Behavioral Health and Developmental Disabilities, but that certainly is an agency that you would want to call in Virginia and its equivalent in Pennsylvania or whatever state you're in if you're listening to this. If you're billing insurance and got a question, call the insurance company directly. Now, be prepared to be on the phone a while, but certainly talk to these folks. And then contact your professional association staff. It's been a few years since I asked the question of my colleagues in the ASHA ethics office, but I think the numbers are pretty comparable. They had less than 100 complaints that were filed regarding ethical standards. So less than 100 that had to be reviewed by the Board of Ethics. All the data has to be gathered. They had over 3,000 inquiries. Part of their job is to answer people's inquiries, to talk them through, to help support them if they're thinking they do file a complaint, or to help them decide this is not something where you have enough evidence to file a complaint. And they do a lot of assistance, at least on the ASHA side. I'm not familiar with the BACB side, but I'm sure it's the same. They do some assistance in thinking, what are some options you have? They don't tell you what to do, but they give you options. So that is a really important step, to talk to other folks. Then you start thinking about what you're going to do. Now, a lot of people, myself included many times, you hear about a problem, you're a fixer, you want to fix it right away. This process takes time. You want to give yourself the time to gather the information, to consider everything so that your decision is the best possible decision you could make. And I also really recommend that you keep thinking about options until you have multiple solutions. I have many conversations with folks about ethical dilemmas, and they often tell me, there's nothing I can do, or I only have one choice. If that's the case, you just need to keep thinking. It may feel like there's only one choice. It may feel like there's nothing you can do, but think a little bit deeper. And then really take time to think about which of these options has the most likelihood of success and the most likelihood that the situation will be resolved, it won't be repeated, and we won't have some unintended consequences that will come back and hurt us in the future. I just really want to emphasize there's no need to rush. On occasion, there's a need to make a decision right away. You got a child crossing the street in front of traffic, you act right away. Absolutely. But there are many, many, many more situations where you can take your time and think through options for resolving. So as you're thinking about the different options you have, thinking about the different outcomes, some questions to ask yourself. Do I have enough information to move forward? Do I really know enough? Would I be drawing conclusions inappropriately because I haven't gathered enough information? If I don't have enough information, is it available to me? Do I have access to it? Can I get it? If you don't have enough information, go back to steps B, where you're understanding the situation, or D, where you're understanding policy practices. And that's then sometimes, as I mentioned earlier, we just can't get it. How would this decision or action impact other people? And this is when you think about clients, students, their families, our colleagues, and our organization. Well, if somebody is implementing a practice which is inappropriate, it will impact them negatively. Hopefully, we can make it a win-win situation where they learn the appropriate approach and they implement it with fidelity, and we move forward with a better approach. But sometimes it's not that way, that there is a colleague that has to have a change in direction that can be difficult. What does it mean about the organization? I tell you, this local hospital, their reputation has really been harmed by the fact that they didn't catch this nurse in the NICU. It looks like there are a total of 7 babies in the NICU that were harmed. Thankfully, none of them have passed away. But boy, the impact on that facility. Will this action resolve practices so a similar situation will not likely occur? That's our ultimate goal, isn't it? We don't want to just take care of this situation with person A and client B. We want to make sure it never happens again, that what we are doing is compliance with policy, with practice, with evidence-based service delivery. Does the action I'm choosing comply with the requirements and spirit of applicable laws, regulations, and policies? And does this action demonstrate my personal and professional integrity? Can you stand up behind it? Can somebody say, yep, Lisa, you did the right thing there, and wouldn't have any question about my integrity? We used to say, would you be okay if this was on the front page of the newspaper? But now it's, it's been blasted all over TikTok, I think is the way it would be. So how do we resolve these? Frequently, it's just by talking it over with somebody, talking it through, discussing it. Sometimes we need to pass it up to somebody with a higher authority to make the change. That it may be that it is a colleague we don't have supervisory authority over, and it may be that by passing it up the chain, the person at the higher level has got the authority to implement something. If you are the person in authority to make a change, what are some options you might have? Well, frequently it's just having a talk with the person. One-on-one discussion with the people involved, understand the situation, and make some reminders about what policy is, what best practices are. And it's often an opportunity for training or retraining. Often ethical scenarios, ethical challenges that pop out show folks in supervisory level positions that we've got a training issue. We didn't do a good enough job onboarding somebody. When somebody new came along, we didn't make sure they understood everything. Or we've got some new evidence in the field and we haven't made sure that some of our clinicians who have been here a long time are up to date with what the new research is. Of course, there are times we need to report internally or externally. Depending upon where people work, there may be internal ethics or audit committees. There may be human resources, especially if there's any sort of issue regarding abuse going on. And so part of our step D of gathering information is to find out what avenues are there for reporting if this is really something egregious. Report to licensure, report to ASHA, report to BACB. And, unfortunately, when I was on the Board of Ethics, there were folks doing things that we needed to take away their certification. We needed to report to licensure. We don't want that person working with clients. But that's a really small number. ASHA's got 120 some thousand SLPs, and there are less than 100 complaints in a year, and not all those complaints are founded. Do nothing. A lot of people just do nothing. Why? It's uncomfortable. I don't like conflict. It's not my job. I'm just going to go to work in the morning and come home at night. It's an easier way out. I would offer to you that doing nothing is making a decision to do something. And that decision is to let what's going on continue. That if you've seen something, observed something, or heard something that bothered you, and it bothered you enough to talk about it with somebody and to do a little research, and you don't do anything, then what you are doing is letting that behavior continue. So I encourage you not to use the option of do nothing unless truly you have no way of verifying. If it is completely hearsay, you have no way of verifying the truth of this hearsay, that's when you have to do nothing. You can't go charging somebody with something if you don't have the data. But I encourage you to do everything you can to find out enough to determine, is there something that can be done? Then you select your approach. And as I said before, you want to select the one which has the greatest likelihood of resolution, the least likelihood of unintended consequences. And then you want to think about how you're going to communicate it. You want to make sure you communicate it in a way that you are credible and knowledgeable, that people don't think you're relying on hearsay or secondhand information. You are credible if you've gathered the data yourself. You want to make sure that everybody knows that you're being completely truthful, that they're not seeing any biases, that they're not seeing that you want to get back at somebody. Many, many, many years ago, I heard of a situation where there was a private practice of SLPs that split apart, and person A from this facility filed an ethics complaint against person at this facility, and then what do you think happened? And then it was kind of a tit for tat. It hurt the credibility of both organizations because they just didn't really try to work it out, and it seemed like it was more a bias, a retribution sort of issue. Ruth Bader Ginsburg made this statement, which is really meaningful to me. Fight for the things you care about, but do it in a way that you will lead others to join you. So present yourself in a persuasive manner so everybody you talk to about this will believe that you have thoroughly researched it and you've come up with the best solution. Okay, then you want to reflect upon the effectiveness. Don't stop with your action. Take a moment to reflect. Did you gather enough information? Did you fully research relevant policy and practice? Did you fully consider many different options? And if a similar situation occurs in the future, would you do the same thing? All right, we'll come back to this as we look at those scenarios. Now I want to share with you what I noticed when I studied the BACB ethics code and compared that with the ASHA code of ethics. They both are incredibly strong ethics codes that address our professional responsibilities. And there are some themes that show up across both of them. A deep respect for the welfare of the persons we serve. Our responsibility as professionals, our responsibility to be honest and have integrity, to maintain collaborative relationships, for how we delegate tasks, and then in research. So I'm just going to hit the highlights. These are phrases I noticed. You're going to find that there are some different ways of wording it, but it sure looks like the same message to me. So honor the responsibility to hold paramount the welfare of persons they serve. In ASHA for SLPs, BACB, prioritize client rights and needs in service delivery. Clearly, we do not discriminate, and that jumps out of both ethical codes. Informed consent, critical to both organizations. In ASHA, there's language that says we shall obtain informed consent with a detailed description of what informed consent is. BACB, comply with all conditions required to obtain informed consent with a detailed description of what informed consent is. That clearly can be a muddy issue, and that's why both of them have been careful to explain it. Record confidentiality is critical for both professions, that we both are obliged to protect confidentiality of the persons we serve and to maintain records and information in a secure fashion. Both of our professions have the opportunity to bill for services, and that feature is addressed in both ethical codes. In ASHA, we see language that says accurately record and bill for services and products dispensed. BACB ethical code, we see identify services accurately and include required information for reimbursement. So the expectation is we are incredibly ethical as we submit reimbursement. Conflict of interest. It's an issue for everybody in healthcare professions, and it is strongly spoken to in both ethical codes. ASHA has the language, avoid engaging in conflicts of interest, and it's got some additional language regarding if there is a potential conflict of interest, how you have to make that very clear. I didn't bother adding all of that. But you see comparable language in the BACB ethical code, where the language is to avoid entering into or creating conflicts of interest. We need to act within our professional scope of practice, our competence. And so we see in ASHA, there's language which says engage in only those aspects of the profession that are within the scope of professional practice and competence. BACB, practice only within their identified scope of competence. So both professions have competency standards, and we are expected to comply with those. We need to keep learning. It's not something that is finished once we finish grad school, once we get our license and certification. ASHA says enhance and refine professional competence and expertise through engagement and lifelong learning. BACB says engage in professional development activities to maintain and further professional competence. Collaboration is present in both codes. ASHA has language which says work collaboratively with members of OWN and other professions. So we're not just limited to making sure we play nice with SLPs, we play nice with everybody. And the same is absolutely true with BACB. Collaborate with colleagues from OWN and other professions. We're supposed to be honest. We're supposed to have integrity. Said slightly differently, act with honesty and integrity, provide truthful and accurate information, but it's the same thing. Delegation, that we all have the opportunity to have assistants work with us, to people that are not at the same level of credential. And so what are the expectations we have as the qualified professional and working with somebody who is a paraprofessional or has less skills than we have? ASHA says we delegate tasks only if those persons are adequately prepared and appropriately supervised. BACB says delegate tasks only after confirming that the supervisee can competently perform the tasks and delegation complies with applicable rules. Pretty strict standards for delegation. And secondly, about delegation, in ASHA, SLPs shall not delegate tasks that are within the SLP scope of practice to other professionals or supervisees. And then BACB says supervise and train others only within the scope of their competence. And so that we've got that expectation that an SLP is an SLP. You can delegate certain tasks, but you have to be careful that you're not delegating the task for which you have a master's degree and license to be able to do. And so that's sorting. And I saw that comparable language in the BACB ethical code. So I have chatted for a little while here. This might be a good place to kind of stop and see what observations folks have about the information, especially about the ethical codes.
Thank you. what jumped out to me, and I'll admit, I've worked, goodness, 20 years plus in the discipline in various capacities. And throughout that time, I've had more interaction than I can count with speech and language pathologists. And I've always gotten along with them, and they've gotten along with me, I
Yay.
believe, for the most part. Um, I wasn't aware how closely aligned our ethical codes are. And it seems to me that that summary shows us that although our technical language may be different, and that is something where we can translate and listen and interpret, we're starting with a very similar a set of ethical values. And I think that really is a common language
Yeah.
that's foundational. And I think it's really helpful for both professionals to know that from the onset of a collaboration, we might approach a need differently, but we're approaching it with a shared set of ethical values and
Yeah.
interest. And I don't think that point is often, it wasn't revealed to me until to just now.
Yeah. Well, it was revealed to me when I did the study for this presentation that I mean, it was fascinating to me as I was reading through the ethical code of BACB, and I went, oh my gosh, this is over here in the one that I know so well from my own profession. Thank you for sharing that, Jonathan. Any other observations?
I would just echo what Jonathan said. The similarities are great. I just keep thinking, I mean, I'm glad that you reviewed them because I think they're so important to bring up as we talk about collaboration. Just to keep in the mindset, again, we're coming at it with the same ethical values, but then coming back to that, the welfare of the client, the needs of the client. We're also sharing that goal, hopefully, right?
Yeah.
So we're sharing that goal and we're sharing these values coming together, and really kind of with that in mind, trying to release anything that's getting in the way of that, anything that's keeping that collaboration from working.
Yeah, I agree completely. All right, let's go back to those ethical situations. We'll apply the ethical decision-making model and kind of see where it goes. So this is our first one, our first ethical challenge. This was AB with the low-tech device that AB transferred to the school. The school SLP identified the need for more vocabulary, organize the icons in a way that would support syntax, and the OT is wondering about, has some concerns about AB's ability to manage multiple pages due to fine motor challenges. So I want to tell you that my application of this is not as comprehensive as you will probably have if you dive into it really detailed, but I just want to hit the highlights of the things that you might want to make sure that you're thinking about. So what is it you want to accomplish? Ideally, it's just the top. We want to create and support a functional use of the AAC for AB. You want to give AB the ability to communicate. But it's often easy to criticize, sadly. And so another goal might be to criticize the BCBA for not addressing fine motor access and broad vocabulary. I don't know about you, but I've been in conversations where people kind of devolve to the second option and they spend way too much time on the negative energy about that. And you got to kind of lift them back up and say, okay, what's our goal? To welfare of the client, let's focus on functional use. So let's learn everything we can about the situation. Well, when you've got somebody transition, you don't always get a lot of records. You don't have a conversation. And so there's a lot of assumptions that we might make that we shouldn't be making. So these are some of the things we might need to do to learn about the situation. How was the device developed? I mean, really, how was it developed? Did they trial other devices in the past? How did they go? What worked? What didn't work? Why did they end up with this device? What do we know about how the family was involved and how the family selected vocabulary and how the family may have been involved in choosing the icons? What level of training and support were provided to the family? So these are just some of the things that you're not going to necessarily know just when this individual transitions to your facility. And then, we've got the OT concerned about fine motor. Well, maybe it's been the same fine motor issue all along, and maybe there was a problem in coming up with a multiple page device that needed fine motor skills, but maybe the fine motor skills have changed. And so is that part of the reason why this isn't working? And as I said, I'm sure there are lots of other things we might want to explore about why this is the current situation, but those are among the things that you will want to look at. So in terms of step C, ethical is definitely the welfare of the client. We have a client that had some basic communication skills that were effective. We've got a broader amount of communication that needs to be occurring in this new environment, and there is concern among the team that maybe the welfare of the client is not being met to communicate in this new situation. IDEA has got requirements regarding communication mode and assistive technology. So the EP team needs to be thinking about this. So that's our legal and policy. And then moral, as I think that both Aaron and Jonathan said, we have this common moral belief that we want to do the best by our client. So I'm going to skip step D. I'm not going to do all steps in each particular scenario, but let's think about possible resolution we could have. Sadly, the top one is a common activity, rehash the problems of the past. As I said, we do like to do trouble talk sometimes. But I think we all might agree that doing a new evaluation based on the current status and communication needs is probably the best step. And let's bring in the entire collaborative team in the facility where the individual where AB is, bring in family, review past records. I mean, if we found that number of things were trialed in the past, let's see if we can talk to the BCBA who trialed those and find out what was not effective. Why didn't it work? Why did you choose this one? And that can inform where we go. Do nothing? Well, what good is that going to do the individual? We have a minimally functional way to communicate, which is not going to meet this individual's needs in the new environment. And so doing nothing really doesn't get us anywhere. But boy, that's kind of easy to do, isn't it? Everybody's got a busy schedule. Oh my gosh, it takes so long to do the AAC evaluation. We've got to find time in everybody's schedule to get it together. We've got to have the OT there for different access methods. We need our BCBA there to look at behavioral approaches, the SLP, and we need to include the classroom teacher to be thinking about new vocabulary, and we need to bring in mom and dad. Well, they don't have transportation. And it becomes hard to do what's the right thing. And that's when it's really valuable for the whole team to come together and say, yep, this is what we need to do. Let's make it happen. Any comments on this scenario with AB before I move on?
I want to go all the way back to where you started, actually.
Okay.
And you said something and kind of resonated with me, and I think it's so important. You don't have to go back in slides.
Oh, okay. All right.
When we experience these ethical violations, these questions, these challenges, there's a lot of history that we're carrying into that moment, and that can kind of set the occasion for an initial response that's not always that helpful.
Yeah.
So whenever we have this challenge, sometimes it manifests, and this perhaps is overly simplistic. We could look at perhaps trying to approach the problem by decreasing something, or perhaps increasing a skill. I'll put it this way.
Okay. Yeah.
When I'm teaching a grad class, and I have students who come to me and say, "Hey, I have this kid in a class, and they're out of their seat all the time. It's disruptive. I want to decrease out of seat behavior." And I say, "Okay, that's interesting. What are some other ways we could approach that?" Another approach would be, say, increasing in-seat behavior. And what's really interesting is the perspective we take.
Oh, yeah.
It very much sets the occasion then for the action that follows. And so when you put up those first two options of, I forget what it was, we can criticize the BCBA, or we can sort of try to take a functional action. It almost conjures some of the clinical decisions that we have to make frequently in just terms of how do we approach a problem. And sometimes the perspective from the very onset will sort of set the occasion for everything to follow. So that first step is really, really critical of seeing this as not a problem to decrease per se, but rather an opportunity to increase collaboration or increase understanding, and try to approach it from that angle.
Absolutely, Jonathan. I really appreciate how you presented that. As you were talking, I also wanted to point out that I mentioned early on, we need to think about our biases. So let's say our prior experience with this BCBA or with this particular school district or with this particular program is negative. And so we come to every following situation with that individual with a negative lens. And we have to just erase that and start again. And that's why it's so important to put the individual first. We're serving the individual. And then secondly, make sure that we know everything we can about it and not just going on a past assumption about a bad experience. And, don't we all do that? Oh my gosh, that is a great school district. You're going to get the best possible services out of that district. And then you have somebody that doesn't get it. Well, why didn't that happen? Or then you have the reverse. All right, let's look at another one. This is the young adult with autism and DD who's now attending an adult day program 3 days a week, concluded IDEA services 5 years ago, had an SGD, but doesn't have it at the day program, and the SLP learns it hasn't worked in years. Okay, so what is, I think our approach is, we need to fix this. We need to give them a good device. So what I'd like to do now is transport us back 5 years. We're at the final transition meeting and before the child leaves. Have we been thinking about the welfare of the individual then? Were we really addressing what was needed? And so these are some of the things that we might be asking in that transition meeting. Where is AC going to live? What will be the communication needs in that living situation? Well, those first two questions might not be answered at the same time. It may be that one transition meeting is going to be talking about finding out where they live, and then you have another meeting where you could be in to talk about communication needs. What are the supports that are there? What do we know about that? What kind of situation will that be? And sadly, I don't mean to be such a Pollyanna to believe that we know this at age 22 clearly. I know life happens and they end up in many different places as they exit the IDEA system. Can we meet with the people in that living situation? Can we work with them? And then, let's find out how this device was funded. Was it funded by the school district, so it belongs to the school district? Was it funded by Medicaid, so it belongs to AC? So let's look at research, policy, and practices. And in this case, I'm thinking about our goal is for AC to have a functioning SGD as they move into adult life. So that is our presumed goal that the team has come up with. And so some of the policies and practices they want to find out is, what's the practice regarding replacement? So before they leave K-12, we should find out, will Tobii Dynavox replace this in 5 years? What's their warranty? What happens if it breaks? Do they come out and check the device? Do you have on-site services? So what is the policy regarding replacement and repair, and then for training? And then what funding is out there that I think that there are too many stories of families and adult service providers not being aware of how the replacement cycle for these devices and what happened at that transition meeting where we didn't tell the family that this can be replaced, where we didn't tell the family this is what you do if it stops working, where we didn't tell the family to take that with you. You're going to have an SLP or a BCBA at the facility where he's going. Oh, sorry about that. I lost my cursor. There we go. So brainstorming in this case, conduct a new evaluation with an interprofessional team, contact the manufacturers regarding training, support, and replacement cycles. And this is where I think we all know we want to look at multiple options, that we may have TD as our favorite, but it might not be the best choice for this individual. And so we want to make sure that we are not just kind of zeroing in on one manufacturer. We like that rep. They've done a great job with everybody before. Well, let's make sure we look broadly. And then meet with the family and adult facility staff to provide orientation to this new device, including troubleshooting and future programming, because we aren't going to be there forever. That funding runs out, that the professionals, there's X amount of dollars that are available, that it is often difficult to bring us back in again. And so we need to have the folks that are living with our person to use AAC devices be as knowledgeable as possible so that the device can be usable. So I think in this brainstorm, all of the options are what we want to do. I didn't pop up with one that we might not want to choose. So thoughts, reactions for AC before I move on. What do you think? Any new ideas that I neglected to include.
I just want to comment that I love your model as it applies to this case because, you know, in our scenario, we're saying, yes, we dropped the ball 5 years ago. However, like when we apply the step by step, we know that, you know, that requires making some assumptions, right? And I think as somebody who's been in this scenario several times on the receiving end, I think you and I talked about this a little bit. I have a few clients. The temptation is to be like, oh, the school district dropped the ball or the parents dropped the ball. But I think we need to think about like the ways in which we provide follow-up and the you know, maybe the parents, the families, the caregivers were told, or maybe those people changed. And so when I think about that information gathering in your steps before we assign blame and say this is yours to hold, not mine to hold, but now we're going to rescue you, kind of thing, that I think I just think there's a lot of value in the model here so that we don't risk, I don't know, retroactively alienating people from their previous teams too, which can be so tempting.
What a good point. I like that term, retroactively alienating. That's a great term. You're going to be working with folks. We live in areas where we know each other. You know, how many of you, you guys have been in the field for a number of years and you bump paths with people that you worked with 10 years ago, 15 years ago, 20 years ago. If we recycle, we want to make sure that we maintain the best possible relationships with everybody we can, except in very, very, very few circumstances. And I do want to acknowledge that sometimes there are circumstances where we do make a separation. But we want to not just help AC in this situation, but if you've got an opportunity to go back and work with the people on that transition team about what you've been able to do for him post exiting the IDEA system, well, you're giving them new ideas. You're helping them. You know, if you see them at the state conference, oh, guess what we were able to do for AC that we talked to, and so you're expanding the knowledge base of those folks that maybe didn't have that knowledge base. Thanks for those comments, Laura. All right, let's go on to the third scenario. AD is a 23-year-old with autism and developmental disabilities, recently began community and residential services with an adult support program. Also received IDEA services with SLP, ABA, and OT. Non-vocal, no functional means of communication. In reviewing the records and talking with the family, it seems that AD was expected to meet certain prerequisite skills of attention and language prior to considering a device. Even notice the phrase, "it's too early," found in the record. Oh my goodness, it breaks your heart, doesn't it? Absolutely breaks your heart that we've got a team of people who just are not current in what they should be thinking about in terms of AAC devices. So what do we want to accomplish? And I think this kind of summarizes what we've been saying thus far. It's so easy to be angry over poor judgment found in the record. But we need to move forward with our goal of providing AD with functional means of communication. So what do we need to learn? Well, probably would be a good idea to start out getting some parental permission. And let's see if we can read all the school records and communicate with school personnel. We all have written reports or read reports where we wish we knew a little more, right? That they just don't say enough, especially with a lot of pressure to get reports done in a short period of time. We don't have these lovely narratives that tell us everything we want to know the way we had maybe 10, 15 years ago. So it's really helpful to be able to communicate with the school personnel directly. Do a deep dive in the records and see if you can get a complete picture of past communication skills, interventions, and results. What was tried? Why didn't it work? What do we know about why it didn't work? And that would be a good way to talk to the school personnel, maybe the classroom teachers who were probably the most realistic view about why things were or were not working. Were any devices trialed and abandoned? Why? What happened with the abandonment? And, you know, how many times have those of us who have even a touch of involvement in this field hear about the device being left on the shelf or being uncharged? You know, so it's pretty hard to be able to communicate if your voice is on the shelf and not available to you. But those are things that we want to make sure we are learning for this case, not assuming because we've heard it so many times before. becomes really, oh, of course they forgot to charge it. That's why that he never got used to the device. So in terms of brainstorming, I think I've got a theme here. Let's do a new evaluation. We've got a good team. Let's have the team do a thorough evaluation. We could file a complaint regarding the professionals who previously served AD. They've got licensure, they got certification. They might be able to be maybe a complaint to the school district. We could do nothing. I think taking the high road is the top one. If in the course of gathering all this information, we see and have clear evidence of egregious behavior, that's when you file a complaint. I'm not saying, gotta say you don't file complaints, but I think when people view your options are to file a complaint or do nothing, they gravitate toward doing nothing. That when I was on the Board of Ethics, the code was modified and it's been tweaked over time since then to try to help people realize that you've got an affirmative obligation to do something. It doesn't always mean you file a formal complaint. That if you have evidence that intervention is needed to fix a situation, as a professional, you need to do something. But don't feel like your only step is to file a Board of Ethics complaint or to file a licensure complaint. There are a lot of things that can be done before then. And I think let's move forward. Let's do a new evaluation. Let's see if we can create relationships and build up these people's knowledge. All right, let me do the last one and then we'll kind of, oh, I got 2 more to do, don't I? Better keep moving. We got a teenager with complex communication needs who communicates with an SGD. They noticed that AE's one-on-one paraprofessional regularly takes AE's hand in a hand-over-hand approach, creating communication on both devices without alerting AE or asking permission. So what do we have here for our goals? We certainly want to honor the bodily and communication autonomy of the person who uses the AAC device, or we might want to change the paraprofessional's behavior, or maybe both. So you want to learn everything you can about this situation. I think one of the first things to do is to make sure you're seeing it clearly. You want to observe AE in multiple situations throughout the day with multiple different providers. You've got the paraprofessional with one-on-one, but you also probably have the classroom teacher, the SLP, the BCBA, who are also using that device. Are we all doing the same thing? Talk with the paraprofessional about background and training and how to support AD. Talk with the other personnel working with AE, excuse me, I'm mixing up my kids here, about the background and training. So diving into this step, which we haven't mentioned in the last couple, is it ethical? Is it legal or policy? Is it moral? Clearly the welfare of the client is here. And I think that we all have become troubled by increasing knowledge about abuse of persons who use AAC devices. And how vulnerable that these individuals can be. We also have become troubled that perhaps some of our methods at supporting those individuals appear to give authority to other people to control the body of the individual. And does that set that person up to be the recipient of abuse? So I think that this is a new area that we all are struggling with, that we are troubled about, and we are diving into. But it all comes back to the welfare of the individual. Legal and policy, what are the policies we have in place regarding the client's assent to touch them? I went to my primary care doctor the other day, and the nurse and the doctor were both very clear about getting my permission before they did blood pressure. So they're being very cautious about coming and touching my body without talking to me about what they were doing, which I appreciated. And then moral is serving the client appropriately. I think this is a time when our research and policy is to looking at what the current body of knowledge is regarding bodily autonomy and the use of hand over hand. I have a colleague who is the national director for the Deaf Blind Center, and she is the person that really helped me understand the negative aspects of hand over hand with many individuals who are experience deaf blindness and how alarming it can be for them and some of her experiences with that. And that's kind of what raised my attention to that. I looked around for some resources to help people if you're wanting to look into this more deeply. It's certainly not an area I'm pretending to have expertise in. It's an area I'm raising for our consideration. But both Isaac and USAC have information on their websites regarding bodily autonomy. And then what are your approaches? Well, we could write up or file a complaint about the paraprofessional, the other persons using similar approaches. But I'm gravitating toward the second one. Let's do some group training. Let's pull in some of the current research and practices. Let's review what we know currently and some of the negative implications, perhaps, of what we observe the paraprofessional to do. Or could this be that you as the observer just went to a training and are hypervigilant, and you've gotten yourself overly exercised about this, and this may be an area that it is not concerned for this particular individual? All right, I'm going to go to the last scenario and then give us a chance to chat about it before we sign off. This is the last one about collaboration. The house manager notices everybody complaining about everybody else. So what's the house manager's goal? What does the house manager want to accomplish? I think we all know that your best services for our clients is to have create one more time, to create a collaborative team for the benefit of all the persons we're serving. Or this person could be just, they plucked the manager's last nerve and she is ready to provide consequences. So I think we want to gravitate toward the upper one. This is when the manager really needs to spend a lot of time observing. And this is when you observe everybody throughout the day, in the evening. You want to listen to everybody, and you just spend a couple days, a couple weeks, just taking it all in. When I started the new job at Longwood University, I was in a situation where a couple people came and did kind of comparable thing for me. And I went, oh my word, what have I gotten into? And so I then spent about 6 weeks doing the observation and listening approach. And boy, I'm really glad I did, because what I first heard was not necessarily the best information. The first to present his case seems right until another comes forward and questions him. So we need to make sure we hear all sides of the story. Ethical, certainly we expect collaboration. It's very present in both codes. Legal and policy, I'm assuming that every residential facility expects people to work together. And then morally, we know we work better as a collaborative team. So the solutions that we might have are individual conversations with professionals. Team building activities would probably be useful here. Or we have some folks whose solution is, I'm not going to do anything, let them just work it out. I'm gravitating toward the first two. All right, before my concluding slide or two, any comments on the last two scenarios before we close this out? We've been here for 74 minutes, that we all are kind of maxed out, aren't we?
Yeah, I think you just covered a lot and brought up a lot of, not necessarily solutions, as we talked about. These aren't to give you answers, but to raise more questions about how to think about some of these ethical situations. And like you said, sometimes it is do nothing. Sometimes you're just looking at it from the wrong perspective. And the more, if you spend that time observing, then the answer maybe isn't to act necessarily. And other times that obviously that proactive and collaborative stance is going to be the best route.
Hopefully, yeah. All right. So I think a decision-making model, as you have said, really enables us to slow down and consider all aspects of a situation. And when we slow down, it tends to be a greater likelihood of a positive resolution. That's, if I think about when we sign a contract, we are given 3 days to get out of it by law, because sometimes we make a decision too quickly. I mean, that's a reminder that making a quick decision doesn't really get us the best resolution. And I think that step-by-step process really assists. I appreciate your feedback that the different steps really assist in getting the right viewpoint, getting our heads focused on the individual that we're serving, as opposed to all of the negative aspects of what we've heard about, and keeps us focused on doing the right thing for the welfare of the clients, the students that we are serving. So I just really want to thank you for spending 75 minutes with me. I appreciate your comments, Aaron, Jonathan, and Laura. I think they enriched the conversation, and I wish this team the greatest success in developing the skills of BCBAs and SLPs as you are serving the persons who so desperately need our services in your area. So thank you.
Thank you so much, Lissa. We really appreciate you joining and presenting this on this really important topic for us tonight. So thank you anybody who joined us live or is joining us asynchronously. And please return to our website to see some more offerings that we have for CEUs at no cost, particularly for SLPs and BCBAs. Have a great night, everyone.